Hello, 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 everyone, and welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Tercera Therapeutics. My name is Rain Bennett. I am your host, and if you were here last week, you might remember that I was on the road and in a random conference room at Beaufort County Community College in my hometown of Washington, North Carolina. I am back in my office with my mug, my Luncheon with the Experts mug, so it's good to be home. Welcome back to the show. And if you don't know me, just a brief bit about me. I'm a filmmaker and writer that's been working with CCF for 10 years, folks, 10 years. And it's been, such a great part of my life, of course, and my career. And I'm just really proud of the work that we've done. And this show and all the other videos that we've created have the same mission in mind, and that's CCF's mission to spread awareness and educate people about neuroendocrine tumors. That is our goal here in the show and all the videos that we've created over those 10 years. And you can find many of those on the YouTube channel or at the videos tab here on the Facebook page. So if you are signing on or have signed on rather, we got good numbers already, guest. I haven't announced him yet. Everybody's saying hello. Let us know where you are from in the world. I see hi from Afghanistan. Fawad, welcome, welcome. And we send you love. People from all over the states already. Great. You all know the drill. Tell us where you're signing on from. I love to see it and how far we reach. Of course, we want to thank Tercera Therapeutics for their support of Luncheon with the Experts. Could not do this show without them. And we always like to say this disclaimer at the top of the program, and that is that the opinions expressed by the guest presenters, as well as the questions asked by the audience, that's you all at home, haven't been created or suggested by the sponsors of Luncheon with the Experts, and CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatment. So that last line is the real takeaway. We're going to give you some good advice. We're going to answer some of your questions, but by no means do we know your specific case. So take that advice, take those answers to your questions to your home team who does know your specific case, and make the best plan for you moving forward. As we all know, this disease is unique and each case is unique. Today's guest, I'm very excited to be spending some time with someone I've worked with before, is Dr. Thomas Odauricio. How are you, Dr. Odauricio?
I'm doing well. Thank you very much, Rain.
Good to see you again. We talked the other day. It's been about a year and a half. I think it was around February of 2020 before the event, the incident, we'll call it, that we've been dealing with for almost 2 years now.
That's exactly right.
I know it's wild. But tell the folks at home a little bit about yourself and where you fit into this neuroendocrine tumor. Where do you work? What do you do?
Thank you very much. So I work at the University of Iowa. We've been there 23 years, and we began our program actually at Ohio State University in 1995, extended it when we went to Iowa, and we have grown it, if you will. We have, we're following happily 2,000 folks with neuroendocrine tumors. And my colleague is Dr. Joseph Dillon. We have a multidisciplined kind of clinic with subspecialties in nuclear medicine and surgery, pathology, radiology, and interventional radiology. So we have about 7 half-day clinics a week dedicated only to neuroendocrine tumors. That's been what I've done for as long as I can remember, and I don't want anybody's eyes to glaze over. So it's been a long time. So I'm very I think I can deal with most of the subspecialties. Any type of question, at least get them started. I'm really looking forward to this, and I thank CCN for the invitation.
Absolutely, absolutely. Well, we appreciate your time, and I'm sure you're going to have a lot of questions from the audience. Maybe
I do, and Rain, I forgot to say, I'd rather be Doc Odo because that's what my patients all call me. It's just a shortened form of my last name.
Doc Odo?
Yeah, I respond immediately to Doc Odo. Okay.
Yeah, absolutely. Hey,
Thank you.
Yeah, you're in charge today, Doc Odo. I appreciate it. So folks, Dr. Odauricio, I see a lot of people. Heather says hello and thank you, Dr. Odauricio. What happens, Doc Odo, rather, often is that patients will show up in the show and they'll love to send shout outs and say hello to you, because the doctors and the experts in this disease usually have a strong relationship with their patients and usually have provided a lot of help for them. So I see the gratitude every week. Yeah, we're having great numbers already. So welcome everybody. Go ahead and start sending your questions in. We're going to start taking them very soon after I get through a little bit more housekeeping. Dorothy says hello from Montreal. Hope the baby is well, Rain. Yes, he's sleeping a little bit better, but thank you very much for that. And haven't seen Dr. Odauricio in a long time. Thanks. We thank you too, Dorothy. Great to see you here. Okay, folks. So go ahead and send in your questions. But listen, we get a lot of questions every week. We try to get to them all. Inevitably, we don't. So if we don't get to your question, or if you have a follow-up question, I want you to reach out to Carcinoid Cancer Foundation here on the Facebook page. You can send them a direct message, or you can reach them at carcinoid.org, their website, and they will get you the information that you need. I promise you. And another thing, this video will live here. It'll be evergreen, as they call it. It'll live here permanently on the Facebook page under the videos tab. So Saturday, Sunday, 2 months from now, you can always refer back to it. Or if there's someone else that you think should watch it, you can send it to them. And starting Monday, we republish it to YouTube for anybody that you know who doesn't have Facebook. Okay. Here's another thing. I always ask you all these two things. You've done a really good job. The benefit of this show, as I was talking with our guest before, is the virtual one-on-one session, right?
Yeah.
You can watch this next week. Or even if you're not here today, someone can watch this next week and get a lot of value. I promise you that. But the real value is if you have a specific question you've been struggling with your disease, is getting that across to a specialist. So if you know someone that would benefit from the show, let them know it's here. I see you all tagging people in the comments. That's perfect. That's what I want you to do. You can also just share the video to their news page and just let them know what's going on. Text them, email them, Snapchat them, whatever you have to do. Let people know. Let's get a lot of people here. That's really the benefit. And the side benefit, I always see the show as having two major functions. We provide you information from experts, and we provide this amazing community where we share experience, or you all share experiences and stories with one another. So there's another reason why the more people that we get here, the more perspectives and experiences we get, and that's a plus. And then secondly, and I'll continue to ask for this because it really helps me do my job. If you see a question in the comments section that you also have or you're also interested in, just use any of those little reactions that Facebook gives you the options to. It starts off with like, but if you hover over it, there's about 6 things you can choose. I don't think you would choose the sad one, but like or love is typically what people use. What that does, though, effectively, they all work the same for me. It shows me there's a demand for that question. If 7 people liked that question, I'm going to know that, hey, Rain, you got to get that one across so we can help as many as people as possible. Okay. Do that for me. It'll be very helpful. Finally, have you downloaded CCF's free Net Cancer Health Storylines app? This app makes it very easy to record your symptoms, your medications that you're on, your nutritional concerns, all that, your moods. So if you haven't, we'll put a link for it in the comments section. And that being said, if there's anything that's mentioned today, a resource, an article, a medication, we will always do our best to put that a link to that in the comment section as well, so that you don't have to jump out of the Zoom or the Facebook rather and open up a browser tab and Google, try to search it and all that. We'll do all the hard work for you. Okay. All right, there we go. Let's start the show. Now, Dr. Odauricio, I'm going to go ahead and start off by asking, I did some work with you all, Dr. Dillon as well, Dr. Howe, your wife, Dr. Sue Odauricio, at Iowa. And obviously I know that the multidisciplinary team there is, world renowned. It's one of the, very well known across the country and in the space. So I want to talk a little bit about, because this comes up a lot. I want to talk a little bit about, well, one, why is that so important? This seems to be almost any doctor, any specialist, that's one of their first lines of defense or advice to someone is like, you want to go, a program wants to have a multidisciplinary team, but also a patient needs to seek out one. Why is that? Why is that so important in your opinion?
Well, I thank you, Rain, for that. the multidiscipline concept is one that they've used for a long time with neuroendocrine tumors, especially because they don't fit any one specialty only, and it's very interesting. In Europe, endocrinology leads most of the centers there, the centers of excellence in neuroendocrine tumors. But in the United States, the algorithm flips a little bit. Medical oncology has taken a much more prominent lead role. But in terms of the multidiscipline, it's not just having them available where you can call them, it's having them in the clinic, where oftentimes we develop something like Mayo's always had, where a person will go to Mayo and they'll see whatever number of specialists they need to see throughout the day. In this case, this is dedicated for neuroendocrine tumors. So we would have Dr. Howell, our surgeon, on a new consultation. We would have Dr. Chandrika, medical oncology. We would have prepared nuclear medicine testing that's been done or needs to be done before we have a chance to talk to the folks coming in. So it's one of those things I believe in, that one kept me in academics for all these 40-something years, and that is that the information rains on you when you have that kind of a multidisciplined situation, and it's an immediate pass through to the folks that are taking the time to come up and see us. So it's a broad education, if you will, and it's first and foremost to somebody like me, because after Dr. House sees a patient and I go in and dare to make a comment about what I think should be done, I then get a lecture and I learn something. I go back and I tell the folks that this is the way it's going to be. So when you say multidisciplined, you want to make sure that the folks are really dedicated to neuroendocrine tumors, and they're not in a building or two away from you, but they're handy and can come and visit you if that's indicated from the visit. And that's what I think has been developed at our place.
Now, it seems to me, and you let me know if I'm wrong here or
No.
if I'm right, that there seems to be an increasing number of multidisciplinary centers. Is that a pattern that's starting to happen?
I think that's true. I think first of all, there's the interested specialty. And for us, the story is short and easy. When I came to University of Iowa, I asked around, and they said the best endocrine surgeon at the time was Dr. House. So I just went over to his office and I said to him, would you consider doing endocrine surgery below the neck? Because endocrine surgeons do parathyroid and thyroid glands. He says, oh, I've been doing that. I'd be happy to. And then I said, well, would you do a clinic with me? And that's when the lightning starts and the thunder. And he said, yeah. And for the last 23 years, all day Wednesday, we have our patients together. And when he does surgery, he sees the patients back in the clinic. So it becomes almost a 2-for-1, if you will, in the clinics. And the same obtains for medical oncology. We have Dr. Chandrika is there the whole week. And so it really works very well to have that kind of, but in terms of instigating and how a clinic starts, I think you really do need to have a medicine person and a surgeon, dedicated surgeon. And that would be that's the basics, the core. And then everything flows from that. Certainly medical oncology is key. Pathology is invaluable. A pathologist that specializes in gut hormones, nuclear medicine people dedicated. And I think whatever success we've had at the University of Iowa has been the nuclear medicine people, because I mean, they were in the lead in developing the various specific scans, the NET scan, the 68 gallium dotatate, And with the help of our faculty and Dr. Sue predominantly, we were able to get an approval, FDA approval for 68 DOTA-TOC. That's the variation of the somatostatin analog. So those two scans are available in the United States. We're very happy about that. And it's just that nuclear medicine has become and is the predominant specialty in terms of the therapy right now, as you all know. And they were very giving and helpful at the beginning. And so little pieces come together, and that's how it starts. And if it endures, and we've been fortunate to have that, it really just gets better and better.
Got it. Thank you. Folks, if you just joined us or joined us a little late, this is Luncheon with the Experts, a Carcinoid Cancer Foundation program. And today our guest is Dr. Tom Odauricio, affectionately referred to Doc Odo, or referred to as Doc Odo by his patients.
Thank you. Yes, thank you very much.
You're very welcome, sir. So listen, we're going to go ahead and start taking your questions. I see them pouring in, so let's get to it. Doctor, how do you feel about lung net questions?
Yeah, I feel pretty good.
Great. All right, we got to.
If I may.
Yeah, you may. We got a couple of them. Okay, so
Okay.
Carly says, I'm a 37-year-old mom of two carcinoid, 37-year-old mom of two. Carcinoid of the lung, had the right lung removed almost 6 months ago, yet I still have a cough and terrible shortness of breath. Is that normal for this abnormal disease?
So it's a great question, Carlin. The symptom, the predominant symptom, as you've alluded to, can be just a cough, a chronic cough, an aggravating cough. And we have seen that after surgery. Sometimes there's a mechanical situation, where a suture in the trachea or the bronchus, the lower tubes, can be there and causing an irritation. The procedure you had I missed that. If they took the whole lung or that whole side of the chest,
she said had the right lung removed.
The right lung removed. So it was, okay, and so there is an adaptive period, and I think the thoracic surgeons can give you, especially the specialists in thoracic surgery that do the lung carcinoids, but there's an adaptive phase that takes some time to adapt. Your other lung compensates, actually gets a little bit larger and picks up a lot of the volume of the lung that's been removed. So it's not uncommon to see that. In fact, we've followed folks for many months. That's not to depress. It's just to let you know that would be perhaps a consequence of healing. And they do have some remarkable meds that can do codeine syrups still serve a good purpose for that. Sometimes that cough, irritation of the diaphragm too can cause that. And so they are usually able to pin down on where it's coming from as you go back. Always go back to your same visit, same folks. That way there gets to be a history. And that's very important for yourself. It's to have that kind of personal relationship with a specialist. And the neuroendocrine people are usually very dedicated to that chronic kind of visits. So it's not a good answer, but it's one that I think the answer is yes, you can see it, and it can last a bit of time. And there's mechanisms that cause it. And I think they usually evolve, what they say, declare themselves, if you will. They'll declare themselves as time goes forward and your healing process continues.
Got it.
Thank you for the question.
Yeah, thanks, Carly. Hopefully that helps. Sending you love. Our friend from Germany, Florian, Good to see you again. Still in the same space. My mother is a lung net. She is now diagnosed with hyperparathyroidism. Could there or can there be a connection with with the net disease? And could MEN1 syndrome be present?
That's a great question, and you're on the track. And I would say almost empirically, yes. The one discriminating thing about it being or not being MEN1 relates to the parathyroid gland. When you have high calcium, and that's usually the presenting cause or presenting symptom or blood work is your calcium's elevated, and that's because one of the 4 parathyroid glands get bigger. The most common parathyroid conditions are a single parathyroid gland that gets large. In the case of MEN1, all 4 glands, all 4 parathyroid glands get large. And so it can then lead to the high calcium and the diagnosis. So if I think you said your mother, if she's had the surgery on her parathyroid, it would be most important to know, was it just the one parathyroid gland or were all 4 involved? And a lot of times they'll take 3.5 and leave a half a gland when it's in the family. But it's that kind of parathyroid problem that can be associated with lung carcinoids. Yes, and oftentimes that's how the 2 you see with multiple endocrine neoplasia 1. And MEN1, be aware, can be familial for sure. Most often they're noteworthy because they're familial or in families, but they can also be sporadic where they just happen. It can just start. And the other P, if you will, that's involved, as you probably know, is the pancreas. And if it is MEN1, the pancreas needs to be followed with CT scans to make sure no little tumors, neuroendocrine tumors, arise in the pancreas. And the other part of the story, not as often seen in MEN1, is the pituitary gland. The pituitary can have a little benign tumor on it. And so those are the 3 Ps, if you will, of MEN1: parathyroid, pituitary, and pancreas. But more often than not, the neuroendocrine tumors of the lung are often picked up like that. We followed MEN1 family and one member of the family for 15 years. And lo and behold, they at a year, right recently, within a year and a half, there was a small carcinoid that was diagnosed and removed. So the lung can have a strong association with MEN1. It's a great question.
Yeah, great question, Florian. Thank you for that. Next question from Joanna. Protocol for octreotide and having a root canal. It seems like a lot of other people are interested in this question too. What do I tell my dentist?
Good. I think that, thank you very much for that. You tell the dentist, that you have a tumor that can be activated, with a procedure as stressful as a root canal. And oftentimes you've also heard that they use epinephrine or something like that to keep the bleeding down. And epinephrine it constricts the blood vessel, but it also can turn on a carcinoid. It can release serotonin. And the way I tell my folks on that is, especially being able to have the subcutaneous octreotide is very important. That's the short acting. A lot of folks haven't started it, or some do, especially if they have the syndrome of carcinoid, which is the serotonin flush and sometimes shortness of breath. You can get wheezing with it. You get a flush, and it doesn't always happen as a systematic a number of symptoms. It can just be 1 or 2 things. The most bothersome, of course, being lightheadedness, because the blood pressure can drop during a serotonin attack. But what the procedures and how long the procedure is going to last is another indication of what you should take before you have the procedure. And we recommend if the subcutaneous form to take a syringe of 100 micrograms or even 200 micrograms with you. And if you're in the waiting room and it's going to be a half an hour before you see the oral surgeon, take the shot, because the shot works, it takes about 15 to 20 minutes to start to work in your body. So, or even if you want, you can get in the chair before they start doing their procedure and take the shot. And usually I always give my cell phone number to my patients, and just for that reason, because they'll often call from the dental office and ask, what to do. And the oral surgeons, there's another constrictor. There's another shot that they can give you that will slow the bleeding down, that you don't need the epinephrine. But it's really the stress. I don't know if you're like myself, but my knuckles usually stay white for about a week after I go to the dental office, and they know that that I don't want to be there. But I think the best way to do it is to be in control of it yourself. Take charge. Take a syringe with you in your pocket, and have it ready. And that will last 2 hours. That gives you full maximum protection for 2 hours. And there aren't too many procedures that go 2 hours, and you still get protection even at 4. So one subcutaneous shot will prevent it, will help, at least help prevent the attack for you. But it's a great question, and thank you, because it's one that that can happen and does happen sometimes in dental chairs. Might just be the stress of it, not even necessarily the procedures.
Got it. Thank you. And thanks for your question, Dr. Odauricio. We have a couple about diabetes and their correlation with NETs. Heather says, have you ever had a patient end up with being diagnosed with diabetes after being infused with Keytruda? I became diabetic overnight with a sugar level of 1287 and put in ICU for DKA. If so, is it reversible? Because my oncologist said it is, but everything I have read says otherwise.
Well, thank you. That's one's starting to run on the fine line of my knowledge base. But Keytruda, I go by MABs if they're an antibody, or NIBs if they have if these drugs have an impact on the enzyme system on the membrane. But the classic one is Affinitor, which is an mTOR. Just to give you the technical term, it's an mTOR inhibitor, which absolutely lowers insulin. And can be associated with, it's actually used for people with pancreatic neuroendocrine tumors that make too much insulin. They actually can control the insulin release. But some of the generations of drugs, these immune drugs, they call them, can act on the pancreas the same way. Your observation is right. You have a large reserve of islet cells. The islet cells are what contain the beta cells contain the insulin. And in general, like for certain octreotide or lanreotide, that even can affect insulin release a little bit, and you can get some high sugars. And that's almost always reversible. The Keytruda, the mechanism I'd have to see, and I think that has to do with dose and how much you had to begin with. So it is quite possible that you could become insulin dependent. That is, you lose that insulin reserve. And I think your observation is keen, and it's happening to you, and it's circumstantial that it happened after you started the drug, Keytruda. So I would put it as together just the way you would have done. And I would, count on taking insulin. Obviously, you just take you just replace yourself with the insulin. Myself personally, have had diabetes for about 23 years, which is, you live by the sword and so on and so forth. But so I've gotten to know a lot about taking insulin, and it's an inconvenience at times, but taking it, and in fact, it may help because it kind of puts your pancreas at rest while because you're taking, in place of your pancreas, you're taking the insulin. And that I've seen happen where you start to recover some of the insulin cells. And so I would say that it probably can, it's probably associated. I really do, knowing what little I know about Keytruda. And but I think it can happen. I agree with you completely. And I think the best thing to do is just, check your blood sugars, take your insulin, and think of it maybe as short term. At the same time, get good at it. And because you really are just replacing one hormone that happens to be a very important hormone, namely insulin, controlling sugar. Good. Thank you for that question.
Yeah, absolutely. And thank you, doctor. Next question from Heather. Heather says, well, and there's a couple of questions, but Heather, I can only get to a couple of them. Heather says, what are your thoughts on PRRT as a first-line treatment after surgery for grade 2 metastatic PNET that has recurred?
So Heather, that's a great question. And, a lot as the FDA came out, the approvals came in Europe and the United States at the same time. Then it became a different kind of thought process. We weren't held to the strict protocols that led to the FDA approval and the EMA approval in Europe. Actually, that hadn't been approved either in Europe, but with the FDA, then they both got approved. With that came then the thought process in just the type of thing. You're talking about a WHO grade 2 pancreatic neuroendocrine tumor. You've had surgery, or you're fortunate enough to get it removed, which we're very big proponents of, as you know, at Iowa, to get the primary tumor out of it as if at all possible. And then what I say, cleaning house, if you will, just sweep it with PRRT. I've had the fortune early on to send 3 patients to Europe with a special request before we had PRRT in the United States on 3 young people who had at least 3 surgeries on a lung carcinoid, and it kept coming back. And all 3 had resurgery and had nothing in the lung at the time. But I sent them to Basel, Switzerland with the request that would they offer a treatment, 1 cycle. And they gave them 1 cycle of PRRT. And these are people that had it reduced again surgically. And they knew that it was going to most likely come back again. I don't know. And it was a low grade pulmonary, but all 3 of those people have, the one that I can think of immediately is now 18 years and no recurrence. So there's validity in your question. The problem always becomes, though, with insurances in the United States, they have strict criteria by the 68 gallium, net spot, that have to have the criteria before the insurances will approve the 4 cycles. And so, that's a little preclusive, because if you just had surgery and you can't see anything, but there's some there, especially if it's a liver, but they've cleaned it out, it's not possible to get that unless you have a fortune, stashed away to do the PRRT, because insurances, Medicare, have been excellent about covering that, as many of you know, at least 80% of the costs. And it's a very pricey procedure, the 4 cycles, but it really makes a great deal of sense. And but I haven't really seen the paper yet from Europe or the United States that have, that have done that, done the surgery, kept their eyes closed, got the primary out, and then treated with PRRT. But I think that's, if you ever get up to Iowa, I'll give you our little schema, because what was a dotted line for a long time between surgery and PRRT, we made a solid line. So the way we shortcut all the therapeutic options, at least that's how we drew it in, is to use surgery straight down to PRRT. So, is it there yet? It's not quite there yet, I don't believe. It certainly has moved up, though, in terms of the options. Thank you very much for that question.
Yes, thank you so much. And folks, just a note, it's try not to ask multiple questions in the same question, and be helpful just to keep them in smaller chunks.
I'll try to abbreviate my. Takes me a long time to warm up for the right answer. That's my problem. I circumlocute and then I get around.
No. I would call it thorough. There's nothing wrong with being thorough. Next question from Rose. I think this is a side effect question. I have recently, in the last 2 months or so, started getting very small pimples on my body. They're very small, about the size of a pencil point. They are scattered, not clustered, don't itch, and they start out red, fade, and disappear in a few days. There may be approximately a dozen more at a time. I'm currently on 30 milligrams of octreotide, Sandostatin, LAR depot. Someone else mentioned the same condition last week's program, but there wasn't any explanation. Are there any thoughts that you may have, Doc Odo, on what may be causing this condition?
Thank you for that question as well. And I have seen what you're describing, and it's one of those initial, I don't know, but they'll tell you. And in fact, one of the patients that had an intolerance to octreotide, the Sandostatin, presented with a neuropathy, actually, of the lower extremities, where their feeling of their feet actually worsened with the shot, and they would sometimes swell. And the other one that I had sort of these little spotty raised areas on her back, on her back. And one of the things I would suggest is, because that's a vehicle, it's carried in these little polymers. And even though polymers are inert, there are some folks that can have a specific, reaction to the carrier, not necessarily the octreotide, because, that's a hormone lookalike. It's very close to what, what was made in nature, God made. And so it's hard to get an allergy to that kind of a drug. So in the case of octreotide, that's a vehicle. Lanreotide doesn't have a vehicle. It's not carried. It's locked within itself. And then when you take the shot and it goes in the deep sub-Q, it releases. So there is no carrier there. It may not be a bad idea to switch. 30 milligrams of octreotide is 120 milligrams of lanreotide. And that's given deep sub-Q. And we have seen intolerance to one, tolerance to the other. So for sure, if you're seeing that association with the higher dose, I'm assuming that you jump from 20 milligrams to 30 milligrams, there's much more protein, there's much more of the drug in that 30 milligrams. And that means there's more polymers there. So it's possible that you've acquired a little bit of an allergy to that. And if you're getting Sandostatin, you certainly, almost every insurance covers the therapeutic indication, which is lanreotide. So I would suggest, rather than stop the drug and just wait to see what happens, which you can do. Obviously, it'll take about 60 days, but or you can just ask them to switch you with the dose equivalent and see if that helps you. Hopefully, it'll take care of it.
Yeah, awesome. Hey, thanks, Rose. And look, that's a great, I appreciate you coming back. That's a great example of what I'm always suggesting to you all, because we get so many questions. Rose had an issue she brought up last week and we weren't able to get to it. And this week we were. So I appreciate you showing back up and continuing to go to the show.
Yeah.
That's the way we're going to get the most benefit out of it. So thanks, Rose. And I hope that helped. Let us know if you have any other questions.
Yep.
Next question from Linda. Question: what progression of treatments or trials are currently recommended after Everlymous/Affinitor becomes ineffective for neuroendocrine cancer of midgut with carcinoid syndrome and liver metastasis?
Thank you very much. That one, I was just thinking about that actually this morning, because, after Everlymous for pancreatic neuroendocrine tumors, certainly the capecitabine temozolomide combination has been very effective. And then I thought, well, does that work for the midguts? And it doesn't seem to have the effectiveness for the midguts. The midguts always stand alone in terms of their response to therapy. Affinitor clearly has been used, as you suggest. It was approved by the 001 series, I believe, from Novartis, and they got indication for the small bowel. Where I would go with that is to see if there is some possibilities of reducing tumor burden. We're big believers in targeted liver therapy, even with some metastasis outside of the liver. When you think about the most important organ in your body you want to save for and keep as long as you can, it's your liver. And clearly, if you're having the syndrome, it's most likely the liver that's producing the majority of the syndrome, because you're making serotonin from those tumors right out of the liver, and they go straight into the system, the body. So I would look to see if there is a liver-directed therapy specialty in your folks, and I can't help but believe there should be. Especially the interventional therapists, they're the ones that really do that work, and see if you could reduce some of the tumor that way to clear up the syndrome. And it sounds like, I'm assuming that the octreotide's not holding it. There is that Zermello, which is great. It's a inhibitor of serotonin synthesis. And that can help in the diarrhea when the octreotide and high doses don't work. But that's for symptom control. But one of the best ways to know is to reduce the burden of tumor from the liver. And as you know, probably that there's bland embolization. You can have Y90 spheres, yttrium spheres delivered to the tumors, and they're very, very effective. And there's even PRRT now being offered again in clinical trials where they direct the PRRT directly into the liver. It's called intrahepatic injection, and that's becoming more studied with good results. We have a protocol at the university, so that'd be another form of embolization of directed therapy. But my suggestion would be to start thinking about reducing tumor burden, depending on and even 25 or 30% tumor burden in the liver doesn't sound like a lot, and it isn't. But if it's an active tumor from the midgut, from the ileum, that can cause havoc. Your serotonin levels may reach 1,000, which sets you up for the syndrome. So my thought, rather than the systemic immune therapies, would be, I would mechanically start to rethink, go back, if you will, if you've had some embolization, see if you could have more. They're very careful on the amount of radioactivity they give to the liver, but your interventional therapists that are usually referred to by your medical oncologist or your gastroenterologist or endocrinologist. So I would think about trying to see if you could go right at the target and make it. And in this case, I'm pretty sure it's the liver.
Got it. Thank you.
Thank you.
Next question from Ronald. Are you using the PET Copper 64 yet? What are your thoughts about this PET?
So yes, I used it once. Okay. And I was very enthused. They're doing them at Excel Diagnostics in Houston, Texas on a commercial basis. So I had this because I couldn't find 68 gallium, came back with a questionable finding in the sinuses of a patient. They called it an occult tumor, and we haven't never found the primary, and we thought that might be it. So I tried the 68 or the copper dotatate, and the resolution, believe it or not, is not quite as good as the 68 gallium. The advantage of it, though, as you might suggest, is that you can take the pictures, you can get the acquisition of the data from later, 24 or 48 or even 72 hours, because the activity of the copper, the copper metal is longer than it is for 68 gallium. 68 gallium or gallium 68 means 68 minutes. That's how long the activity lasts. So when you have that scan, it's timed very carefully. So the activity is maximum when you get the scan, and they make it. Whereas with copper, I stand to be corrected, but I believe the half-life, what they call the radioactive half-life, is at least, I think, 12 hours, which means then that half of it's dissipated. So that gives you a longer time to be able to take the pictures. So there's a little advantage that way. Resolution was a little disappointing. And there was another kind of defect, not defect, but maybe a little less positive aspect of it. And I cannot recall it right now. I apologize for it, but I was not, and nor was my people, the nuclear medicine people. And we've probably been reading galliums, for a long time. But the ability to see, and they called it what the gallium called it. It really was inflammation, because inflammation will give you a false positive. And it's really not a false positive because the receptors are there on those white blood cells. So, but inflammation is one of the things, and FDG PET's the same way. You just have to be careful that inflammation doesn't look like a tumor. And usually the nuke people are very, very good.
Got it. Thank you.
It's a great question, though, and it's coming more and more, but there's some advantage to the copper.
Got it. Next question from Mirjana. I hope I'm pronouncing that correctly. Hello, I just started Lutathera treatment. I have 3 more treatments to go.
Good.
I know about the side effects, but can you tell me a little bit more about the long-term effects?
So I think if the long-term effects are really kind of when you say long-term, you say long-term so long that they never go away. And the one thing that we always watch for, and it's especially important, is your hematologic status, your blood status. Some people are more sensitive than others to that radiation that you physically get in the bone marrow where your cells are made. The platelets are there, and the white blood cells, granulocytes that fight infection, and the lymphocytes, and the red blood cells formation. So that's where all the action goes in the marrow, and that's where you can get, and that's why the dosing is very calibrated to keep the toxic dose to the marrow totally down with the 4 cycles. So they're protecting you with the amount that they give you. But we've seen some white blood cell folk that go low and have stayed low for several weeks and then start to come back. Usually the platelets are one of the first things to go low, not dangerously low, but from, let's say, 350,000, they may even get down to 88,000. For platelets, you want above 50,000 so you can clot. But platelets are the first to drop, and it usually happens in about second or third treatment. But they watch that very carefully. When they repeat your blood work, you'll notice that the CBC, the complete blood count, is gathered. And they'll make a decision. If your blood count hasn't come back fully enough, they'll hold off the treatment, because you need about a 2-week window to order the drug, so it'll come in 2 weeks from the time you order it. And that's because of the shipping and whatnot. Most of it's made, I think a lot's made now in Italy. And I thought they had set up a factory in New Jersey, but I don't know the status of that one. So, but those are what, so the long term, there's sometimes hair loss, but that always comes back. And it may or may not be noticeable, but it's kind of patchy hair loss, but that does recover. Fatigue, you may have had a little fatigue for a week or two. That almost always returns. Some people have it for just a week. Other people have had it for as long as 3 weeks, but they'll tell you they gather their strength back and they start feeling good. But those are the big ones that I know of. And the marrow is the one that you want to watch very carefully. The kidney is really not an issue. They work on, kidney is another organ, what they call organ limiting toxicity. But for lutetium 177, that it's really not. But the lutetium in the bone marrow has to be watched. So I think that those are the things that I know, and we followed, many for a long time. We've been actually doing PRT since 2000 with clinical trials. So we've had a pretty good experience on that.
Next question from Karen. Hey, Karen, good to see you again. Does this cancer cause low blood pressure at times, or could it be the lanreotide injection?
So it's terrific. Thank you, Karen. So the answer is yes, it can. And I'm thinking specifically of the small bowel ileal carcinoid tumors that make serotonin. And what happens is, you've probably heard of the E's that you want to avoid, or things that can precipitate serotonin surges. That's exercise. Even eating can release serotonin. Decongestants like ephedrine that we talked about earlier, that's an E. And ethanol, wine can do it because it stimulates the release of serotonin from these tumors. It doesn't everybody, but when you have a tumor making an extra pound of it, then it can become dangerous. So in that response, serotonin has two actions. There's an acute action and a chronic action, okay? And you think of the chronic elevation of serotonin and guaranteed loose stools, 5, 6 a day, usually ending by noon, starting at 6 a.m. in the morning. But the acute release, the sudden release of a bolus is just like, this is where I get, because I'm so excited, I went to, where was it? Yellowstone Park. And if you watch the geyser and you sit there, you'll see the geyser go off. And as it's going up, it's coming down. And serotonin is the same way when it surges. It goes up and starts to break down. But when it goes up fast, it causes a drop in blood pressure. So tinnitus, ringing in your ears, you may have a short period of that. You may have lightheadedness where you want to grab something for a second if you're standing. and you just had a serotonin rush, and they don't last more than 30 seconds, most of them. But those, in answer to your question, yes, your blood pressure can be very labile in some folks, depending on how often you release high levels. But the chronic high levels you adjust to, but you'll have that diarrhea as more of a chronic complication. And that's why octreotide, lanreotide works, because it blocks serotonin at the intestinal wall. So you have two actions of serotonin, two actions of sandostatin or lanreotide, and that is it physically blocks the serotonin causing the diarrhea, as well as causing the serotonin from the tumor to be slowed down. Two actions.
Thank you. Question from another Karen. Any new treatment options on the horizon for receptor negative lung nets with metastases to the liver?
So there is on the horizon. And if you want to look it up or Google it, it's CXCR4. That's the name. It's a exotic type of receptor. That's not the real receptor, but that's the one it attaches to in the bone marrow. So it's responsible kind of for the regulation of the stem cells, but they've now made a scan like the NetSpot for the CXCR4, and they also have a therapy for the CXCR4. Okay, Pentixa, Pentixa, THER is the treatment, and the scan is called Pentixa 4, Pentixa FOR. So, and we've had quite a bit of preclinical work done. Again, it's nuclear medicine with Dr. Sue. And the reason why I tell you what it is, it's what they call a cytokine, is that the marrow can be involved when they do the treatment. So that's going to have a little more difficulty in terms of being able to use the treatment, but it's a form of PRRT, Karen. And our pathologist now does a special stain for all the lung tumors. They stain for somatostatin receptors, but they also stain for the CXCR4. And the more loss of the somatostatin receptor, it seems the more formation of the CXCR4. So that's a potential PRRT that's going to be very exciting and helpful. We think for like small, God forbid, the disease, small cell cancer of the lung, but atypical carcinoids will often have the CXCR4 amenable to therapy without any somatostatin receptors. So in answer to that, I think that's where that is going. It'll be another form of PRRT, probably be a few years.
Got it. Okay, I think we'll have time for, depending on the length of your answer, one question, maybe two. Marilyn says, do you have any experience with numbness and tingling in the feet of NET patients?
The answer is in NET patients per se. So that brings up two things. So when, in other words, is the tumor making? Remember, these are hormonally active, aren't they? Even though we say they're non-functional sometimes in the pancreas, they could be making something we can't measure yet. So that would be called like a paraneoplastic kind of phenomenon, the numbness or tingling. It's called paraneoplastic. So it's somehow related to maybe the tumor. That's possible. And neurological manifestations are, I would say it's uncommon. I give it, and usually I always give it a grade of, can happen and this and that, but I would say uncommon, but possible. The other then is, does the drug itself? And I shared with you early on that I've had a case of somatostatin intolerance presenting that way with numbness and tingling. Also remember, if your sugars are going wacko and they're dropping a little bit fast, that certainly can give you numbness because you're losing sugar out of the nerve endings, and that can react on you. So you have to think of other metabolic things that could be doing it too.
Got it. Well, thank you for
There's more questions.
Well, I mean, there's lots of questions, Doc Odo, but we have reached the hour mark. That is going to be our show for today. But Dr. Odauricio, I appreciate you so much, sir. I appreciate you being here and spending some time with us and all the thoughtfulness and thoroughness of your answers. Thank you. Thank you.
It's been my pleasure, and I really appreciate the opportunity. Thank you very much.
Absolutely. And thank you all at home, as always, for joining us. And we hope this program helped answer some of your questions. And listen, we had a lot of questions today. We had a great turnout and a lot of questions. So this is exactly the point that I reiterate all the time. If we didn't get to your question, or if you have a follow-up question, please, I urge you to reach out to Carcinoid Cancer Foundation program. This is our job. They will get you the information that you need, or they will get you the information of the person who can answer those questions. So this is what we're here to do. So please follow up. Come back each week, as we saw with Rose. If you didn't get a question answered this week, next week we'll try again. And if anything, this just shows me that we perhaps need to have Doc Odo on the show again sometime soon, if he's willing.
I'm ready at the drop of a hat.
He's ready at the drop of a hat, folks.
My grandkids are tired of hearing me, so I'm really...
We're not tired of hearing you.
I'm really anxious to...
So please do that at home. And I did get a question from Ruby about where can we get one of these cups. Well, I had these custom made, but perhaps I will talk to the foundation about how we can bring that to you all. Great question.
Oh, that'd be, yes. And after there, it's all distributed, allow me the chance to get one myself.
Absolutely. We should send it to our experts for a thank you gift. Okay. So, and finally, thanks to our presenting sponsor, Tercera Therapeutics. We could not do this program without their support. And my name is Rain Bennett. I have been your host. Thank you for watching, as always. And please join us next week, for Luncheon with the Experts. Stay healthy.
Thank you so much. Peace to all of you. Thank you.
Stay safe, everybody. Bye-bye.